So thank you very much. I appreciate the opportunity to talk to you about bicuspid aortic valve, surgical reasoning, at least my surgical reasoning in bicuspid aortic valve. Of course, since this is the GenTAC conference, we'll focus mostly on the aorta in the presence of a bicuspid valve. Learning points. There's, I think, a growing acceptance that the threshold for intervention should be no different for bicuspid than tricuspid valves. There's no evidence that the dilated BAV-associated aorta at any given diameter is more likely to dissect than that associated with a tricuspid valve, maybe even less. The second learning point is that there's a growing acceptance that we do not need to be overly aggressive with the root or the arch. And third, recognizing simply that there's no perfect approach to the valve. Repair is imperfect, perhaps improving, but still imperfect. Biological valves, of course, continue with limited durability, especially in the young. And mechanical valves may require less warfarin, but still some. Those, of course, are familiar concepts, but they have implications for our threshold for intervention in the presence of a bicuspid valve. Disclosures, sadly, I have none. Of course, there are enthusiasm for intervening on the bicuspid valve. Was stimulated in no small measure by this publication from the Mayo Clinic, Jesse Edwards, about the incidence, the observed incidence of bicuspid aortic valve among people with fatal dissections in Olmsted County, where it was very much overrepresented. And of course, this was fueled by the observation from the Irad database that dissections can occur well below 5 centimeters. In fact, rather alarmingly, the idea that up to 50% of dissections happen in aortas that don't meet the commonly accepted threshold. And that, of course, as we're all familiar, led to the more aggressive posture that we've seen over the course of the last 10 or 15 years. The problem is, I think, that an aggressive approach has a very profound impact. And this is now over a decade ago that I saw this patient when I was at Mayo, who was a young woman, newlywed, was found to have a 4.3 centimeter ascending aorta and a perfectly well-functioning bicuspid valve. She was told at her home institution that she needed to have a composite root replacement, could not have children because even if she had the children, or had the operation, if she had a pregnancy, she would be at too high a risk of dissection. So she, despite our reassurances at Mayo that she would likely be just fine, she went back and had a composite root replacement, etc., and had her tubes tied. This makes the point that once you ring the bell and tell somebody that they have a time bomb in their chest, it's very difficult to unring that bell. And we've seen other things as well. This is a text from a surgeon in New England about the 46-year-old sister of a patient that he had previously operated on. She had a 3.8 centimeter aorta, normally functioning valve. She was advised she had a time bomb in her chest and needed a root replacement. Again, it's hard to unring that bell. And of course, despite the fact that we all think that we can do surgery with almost no risk at all because we're such great surgeons, it's a complex business and things happen. This was an unsolicited email from a plaintiff lawyer asking for an expert witness about a 59-year-old man who had a functionally normal bicuspid valve, an aorta at 52 millimeters, who underwent elective surgery, sucked air, and died. So complex things lead to complex problems. Well, of course, over time, we've seen that the observed risk of dissection, even in a bicuspid valve patient, is quite low. There may be aortic dilatation and aortic interventions, but the risk of dissection is relatively low. And since most people have small aortas, the risk of dissection with a small aorta is low. You need the denominator to calculate the risk, and it's the risk that is relevant. And of course, the Oxford Vascular Study has shown that up to 50% of patients with acute dissection don't even make it to the hospital. So the question is, with this study from Irad, is this really a survival to hospital cure, or curve rather? In other words, we don't know what the diameters were of the patients who never made it to the hospital. So this notion that 50% of dissections happen below the accepted threshold, I think we need to look at that with some degree of circumspection. Furthermore, if you apply Bayes' rule, Bayes' theorem to the problem of bicuspid aortic valve and acute dissection, you come up with a pretty darn low risk of dissection, which it's hard to have an operative risk less than 0.1%. This, in fact, has been borne out clinically. Meta-analysis that was published just a couple of years ago, demonstrating that in fact, size for size, the risk of dissection may actually be less for a bicuspid aortic valve. Dissection, rupture, or death may be lower for a bicuspid valve. So there is some evidence to support the notion that we need not be so aggressive. We should pull back a little bit on our recommendations around the aorta associated with a bicuspid valve. Histologic abnormalities, this is a study we did here at the MGH, demonstrating that in fact the histologic abnormalities observed, bicuspid versus tri-leaflet valve associated aneurysms, size for size, may actually be less. And so how do we make the surgical decision now? I've included here the AATS Consensus Guidelines, which are the same as the ACC AHA guidelines. And I've included this figure, which makes the point that at the end of the day, we try to look at the risk of aortic dissection, which of course goes up with age. We also look at the surgical risks, which also go up with age, and the diameter, the impact of aortic diameter on risk, and have to set a surgical threshold where those all balance. But in the end, I think that we can say that over the course of the last 10 years, we've become perhaps less aggressive, not more aggressive, which I think is reasonable. Second question, how aggressive should we be with the root or arch? There's increasing recognition, I think, that the bicuspid aortic valve associated aortopathy is not uniform. There are several different morphotypes. There's a supracoronary aneurysm, typically associated with stenosis, a very Marfanoid aneurysm, which is associated most often with regurgitation, and then a tubular type or saccular type of generalized dilatation. And there have been a number of studies, this is one we did at Mayo some years ago, demonstrating that if you do a supracoronary graft, as opposed to, or separate valve and graft if the valve needs to be replaced, as opposed to a composite root or a valve-sparing root, then in fact the fate of the unreplaced root, now that's assuming that it was not significantly dilated at the time of surgery, but the relatively normal diameter root at the time of intervention seldom requires reoperation. And this has been confirmed by others, and every few years you see another one of these presentations at the AATS showing the same thing. So the fate of remnant sinuses of Valsalva, provided they're not significantly dilated at the time of the original surgery, you do not need to do a root replacement. Again, that's been an evolution, I think, over the course of the last decade, being a little bit less aggressive with the root. After all, if you do a root replacement, you've sort of automatically given patients right coronary ostial and left coronary ostial disease. Their ostia are not normal after that. What about the arch? Again, a study that we did at Mayo that demonstrated that there were no reoperations for arch dilatation in over 400 patients followed up for a number of years. And this is borne out. The same kind of notions have been borne out by other studies, and it appears in the AATS guidelines. The indications for intervening on the arch, 50 millimeters. That's when really asking the question, should we do a hemiarch replacement, 50 or even 45 millimeters below at the time of cardiac surgery. And I will close, since I'm running to the end of my time, just to make the point that valve repair is still in evolution. We surgeons like to talk about valve repair, but the long-term outcome is still, I would say, we should be circumspect about it. Now, this is a paper from just a few years ago from Cleveland, showing the percent of patients with AR, aortic regurgitation, greater than 2+, hits the 50% mark at about 6 years. Now it flattens out somewhat. Notice that the beginning of this curve is at 10%. So valve repair, we're enthusiastic about it. We like to think that we're getting better at it, but it's still not a perfect solution by a long stretch. Valve sparing route in BAV looks promising. I'd say that we do a significant number of our patients who get valve sparing operations have a bicuspid valve. But after all, if the reoperation rate for a bicuspid valve alone is what we just saw on the previous slide, can we expect it to be much better after a valve sparing route? Now, Jabrin El-Khoury would argue that if the route is significantly dilated, that they will actually do better in the long run, have a lower risk of reoperation if you do a valve sparing route type operation rather than just intervening on the cusps. But I think in the long run, while there are many people with bicuspid valves, young people with bicuspid valve and aneurysm who would like to have a valve sparing type operation, I tell them all that sooner or later we will be back, and they have to accept that, I think. So I will close where I began. Growing acceptance that the threshold for intervention should be no different for a bicuspid valve than that associated with a tri-leaflet valve. A second point, a growing acceptance that we don't need to be overly aggressive with the root or the arch. Whatever the embryology of the root and the arch, this is not cancer. We don't have to get clean margins. The clinical behavior is not such that we have to be overly aggressive. And finally, just again to recognize there's no perfect approach to the valve, and the implications of that importantly are that if you have a patient, obviously, in the office who has a well-functioning bicuspid valve and only moderate dilatation of the ascending aorta or root, I am reluctant to recommend a surgical procedure for them, because whatever we do to their valve is not going to be a very permanent solution. So I think the toughest situation is always the patient who has a well-functioning bicuspid valve and moderate dilatation of the aortic root. And my plea would be for us to be circumspect and not overly aggressive. So with that, I will close and appreciate the invitation again to participate in the GenTAC Aortic Summit 2020. Thank you.